Good day everyone. My name is Dr. Kharthik. I'm from Ministry of Health, Malaysia. Before I present my topic of presentation today, let's have a look at this radiographical imaging. What can we see here? There is a right neck of femur fracture, but most importantly, how many spinal columns can we appreciate here? Which brings to my topic of presentation today. I'm going to present a case of atraumatic neck of femur fracture in pregnancy. In such cases, would you fix the neck of femur or deliver the baby first? This is the unresolved conundrum in multidisciplinary management. I hope my presentation today will be able to provide a fresh perspective and approach to the dilemma. In introduction, femoral neck fractures in pregnancy in general is uncommon and most of the cases were reported in traumatic in nature. However, a minority of them were atraumatic in nature and a subset of them are known as transient osteoporosis of hip. Transient osteoporosis of hip is a self-limiting condition that leads to a temporary loss of bone density in the femoral head and neck. It is a diagnosis of exclusion. Significant differential diagnosis includes avascular necrosis of the femoral head, osteomyelitis, metastatic lesion, and septic arthritis. It is grossly underreported as pelvic and hip pain in pregnancy due to the misconception about the perceived risk of radiation from radiographical imaging, and MRI is the gold standard diagnostic tool. In our case today, we have a 29-year-old primigravid at 33 weeks 4 days of pregnancy, presented to us with an acute onset of right hip pain. She described the mechanism of action as a sudden onset of pain while changing direction when walking. Hence, why does she need a plain radiograph urgently? Combined with the trivial nature of the pain as well as a positive examination finding raised the suspicion of possible fracture. And what might have been a precipitating the factor? She had the right hip pain at 27 weeks of gestation, which was initially treated conservatively as pregnancy-related pelvic pain with physiotherapy and analgesic. The pain did not resolve and the condition worsened over time. Before we confirm the diagnosis of transient osteoporosis of hip, we performed a series of laboratory, radiographical, and histopathological analysis to ascertain our diagnosis. Unsurprisingly, the vitamin D level were deficient, yet the other electrolytes, including calcium and phosphate, were of normal level. Histopathological analysis of the bone sample reported as scanty trabeculae bone with no atypical cell. A bone densitometry scan performed after the delivery found that the patient has osteopenic femoral bone with the T-score of negative 2.0. A CT scan on MRI not performed for our patient as the urgency of a management precedes the need for an MRI. A multidisciplinary team convened decided for a single setting surgery to deliver the baby via the cesarean section, followed by the screw fixation of the right neck of femur. This is the post-operative radiograph imaging shows the cannulated screw fixation of the right neck of femur. In our discussion, antepartum diagnosis of neck of femur with transient osteoporosis of hip in pregnancy is rare. Very few publications relating to the management of such cases currently available. Rare pathologies such as TOH are underreported as pelvic as well as hip pain in pregnancy due to the misconception as I mentioned earlier. This theory is supported in our case where our patient presented multiple times for a similar right hip pain. Due to the limited number of reported cases and a variation in gestation at the point of diagnosis, there is no consensus yet on the optimal management. At the moment, we have two options available for surgeons in the management of such fractures: a head-preserving surgery or a head-sacrificing surgery. Despite having no consensus on the management, most authors preferred to preserve the femoral head where possible, irrespective of fracture pattern. Nonetheless, the failure rates are high and many proceed to arthroplasty. Traditionally, 3 parallel cannulated screws had been preferred. Several paper reports primary management with arthroplasties, although insufficient time has elapsed to evaluate the associated complication in this population. It is widely accepted that preservation of the femoral head in young patients is preferable due to the increased functional demand and subsequent requirement for revision. Our recommendation is that there is a greater need of awareness among health professionals to start vitamin D supplementation in pregnant women from 10 weeks onwards of pregnancy, and primary care physicians, including the emergency doctors, must be aware of the conditions such as TOH in pregnancy, and any degree of suspicion warrants a referral to a tertiary care center. MRI is a good modality to identify the early signs of TOH as well. In conclusion, Potential patients with TOH must be detected early in pregnancy and intervene. Mandatory orthopedic consult for pregnant patient with hip pain regardless of gestation, and those with high index of suspicion must be advised for MRI. These are my references and below are my contact details. Thank you for listening.